My name is Michael Reich. I'm a faculty member at the Harvard T.H. Chan School of Public Health, and it's an honor and a pleasure for me to serve as facilitator for the closing session, the closing panel on this first day of the global webinar on rethinking malaria in the context of COVID-19. So we have three distinguished panelists and good friends of mine who will be with us in this last session. We have about 40 minutes. I'm going to give each one a very brief introduction. They bring a wealth of experience and expertise in different areas, and we're really quite lucky that we could get them here today to reflect on the two really interesting panels that we've had. So first is Uche Amazigo. Uche is the former director of the WHO African Program for Onchocerciasis Control, currently head of a non-governmental organization called the Pan-African Community Initiative on Health and Education. She is active in health and education planning at the state level in Nigeria, and her original training is in biology and medical parasitology. Deborah Atobra serves as the director of the Center for Gender Studies and Advocacy and a senior research fellow at the Institute of African Studies, both at the University of Ghana. She's trained in African studies and has a particular orientation towards gender. And third is Mohamed Pate. He recently served as global director of the Health, Nutrition, and Population Global Practice at the World Bank. Previously was Minister of State for Health in Nigeria, and he's currently the Julio Frank Professor of the Practice of Public Health Leadership at Harvard, a colleague with me, trained in medicine and management. In this panel, we want to reflect on some of the themes that developed in the two sessions today and address some of the issues that were raised in the papers and the discussions. In particular, I'm going to ask our discussants to think about specific actions that we can take. What can we actually do to improve malaria governance in the community, to decolonize, to get better data for actual action on malaria, and how can we get strategic communication? How do the different levels, global, national, and community interact? How can we get back on a positive path towards malaria elimination? These are tough questions, and it is a critical time, not only in terms of COVID, but all of the other infectious diseases around the world. So let's start with malaria governance and communities. We heard about the challenges of actually engaging communities again. We heard about the need to shift to a paradigm of social determinants of health and moving back to primary health care, engaging communities in primary health care around malaria. Let's start with Uche. I'm going to ask the discussants to keep their comments relatively short so that we can give everyone a chance and cover lots of different topics. So Uche, thoughts about the community and malaria and PHC?
Thank you. Thank you very much, Michael, and thank you for inviting me to be part of this very, very insightful, very good discussion. I have learned so much reading the papers and listening to the presenters today. Thank you. And thanks to the organizers as well. For me, community is the owner of the problem, and so a resource for evidence, for information. No matter how we look at it, unless we bring this partner to be actively involved in rethinking malaria elimination, we may be going around the circle for a much longer period. So let me take the issue of how can we bring them on board? We need to encourage ourselves to be more actionable, I think, in the way we look at community participation and engagement. And I very much admire the presentation of Dr. Coleman, Nee, and the colleagues. We need to allow communities to understand that they are part of the group that designs the Rethinking Malaria Elimination Program. So far, they have been very passive in the decision-making, in designing, in implementation. Even the data we gather from the communities, as the speaker said, the data goes up and they have no feedback from the data. So there is so much the communities can provide that will help us in rethinking our strategies for malaria elimination. They are the owners of the problem, and so let us allow them to bring the resources they have and to be part of the solution. Thank you, Michael.
Uche, you're one of the strongest advocates of community-directed treatment for onchocerciasis. And do you think the same approach can be used for malaria?
Yes, Michael, to a large extent. I know malaria is not only for distribution of materials or distribution of tools, but there are a large chunk of malaria elimination components that the communities can play a very important role, and the lead role for that matter, if we give them the opportunity to design what they consider will be the best approach. The challenge we have here is our own perception. We need to decolonize our perceptions, the perceptions that not only the global northern researchers have, but even the African researchers, our perceptions about our communities need to be decolonized. If you read the paper from Jesse, it only takes that angle of the European that came to decolonize, but we need to stretch it further and decolonize our own perceptions about communities. Then we bring them on board. We challenge them to co-design, at least co-design with us. But better still, as the CDI did, we asked communities to design, and we accepted their design. We allowed them to implement their design, and that was what brought the success of the story.
Thank you.
So I would really want to do that.
Thank you for that perceptive point. Mohammed, I'd like to ask your views on this question of community engagement in primary healthcare. You've worked on this both within Nigeria, and you've also addressed those questions in one of the most important global institutions on health, the World Bank. How do you approach and think about engaging communities in primary healthcare for re-energizing the fight against malaria?
Thank you. Congratulations to all the panelists, the teams that prepared the papers for this seminar. I think as a central issue is that of governance. And if he laid out for society, sets the agenda, assigns authority, makes decisions, and holds accountable actors within it. So at the community level, and the issue of community engagement, as Dr. Mazigo mentioned, I think it requires ceding power to communities. Now, what will it take to do that? It basically requires leadership, and leadership at subnational level, at national level, but also the rights of those communities and the capabilities that in those communities to contribute in co-designing, implementing, in some ways even allocating the resources. So at the end of the day, that's really what it will take. There is a dualism. I think the paper from Ghana laid it out more clearly, that institutions that may be traditional or religious and the more externally legitimate institutions of the state, and those coexist in almost all communities in Africa. So how do you reconcile that? It will take leadership. It will take actors enabled with this understanding and the tools to be able to engage, not tell communities what to do, but to be able to listen and bring them in co-designing and co-implementing and holding each other accountable. That is what it will take.
Good, thank you very much. You know, as I was reflecting on the discussion about decolonization in the first session, it made me think that both yourself, Mohammed, and Uche have both held leadership positions at critical institutions, some of the most critical institutions involved in public health in Africa. And it's clear we need more of that. Deb, I'd like to ask for some of your perspectives, particularly from a gender perspective. We heard two sessions today. There was no discussion that I detected of gender. What do you think about the gender dimensions, both about community engagement and decolonization?
Thank you very much, Michael, and thank you so much for having me in this workshop. I feel very privileged to be part of the discussion. I have learned so much within this time, and community-led intervention has been stressed. But I think also that we need to appreciate the fact that communities desire to be attributed some agency. Communities do think that they are able to express agency and to take action on their own accord and to make interventions on issues that affect them and their health. But then over time, we haven't really accorded them this kind of respect and also agency to allow them to make such interventions. And I would make particular reference to a community in Ghana, which is the Manya Krobo community, which had very high prevalence of HIV/AIDS. Over time, and within a very short time, HIV/AIDS incidence in the Manya Krobo community dropped very drastically. And the data actually points to the intervention of women. And I'm referring to queen mothers and grandmothers who mobilized to work to reduce HIV infection. And I think there's a lot to learn from this particular example. And so women who are the primary transmitters of culture and socialization and health consciousness in our communities are able to play these roles in making a lot of change in controlling and eliminating malaria in our communities. And I believe that these are the aspects also that we have actually undermined, and we have ignored the interventions of women in our efforts to control and eradicate malaria.
Wow, what a great point. You know, I just have this image of a new organization, Mothers and Grandmothers in the Fight Against Malaria. Do you have any thoughts, Deb, about how to actually mobilize mothers and grandmothers for malaria?
what happened in the Manya Krobo case, which I happened to do some work there, occurred because the mothers were very, very overwhelmed. And in the wake of HIV/AIDS, they also saw some exploitation, coming into the community, where people were coming in and taking advantage of their predicaments to work and also to do programs, and they did not think they were benefiting that much. So they mobilized themselves and formed an association. They wrote their own grants, did their own programs, worked with Family Health International, and got the technical support and made interventions. They incorporated some health education in some of the traditional practices. And so even in certain rites of passage, they spent time to train young girls and young boys about sexual and reproductive behaviors and practices. And this yielded very, very, very successful results. And so it is possible to mobilize. And as Coleman said, many of these elderly people are available, and they are not passive participants of their communities. They want to be engaged, to do all kinds of things. And it may interest you to know that this group of women I'm talking about have not had formal education, but they were taught lessons on HIV/AIDS, and they were able to do so much. And I believe that this is a good practice we can import into our fight against malaria.
Good, thank you very much. This connects to one of the themes that we found in our discussions over the past 9 months on Rethinking Malaria. And that theme is to denormalize malaria deaths. That malaria deaths have become just seen as part of the way things happen, and they need to become something that people care about, something that people count, something that become visible, and something that is viewed as no longer acceptable. Part of that change in perception about malaria and malaria deaths really requires political commitment. And I'd like to move to that as a next topic. This is as anyone who knows me, is a theme close to my heart. It was discussed as well by Professor Mokuolu in talking about the engagement of stakeholders. But I'd like to ask you, Mohammed, you've sat at the centers of power, both within the largest country in population in Africa, and you've sat at the centers of power within the World Bank. What's your sense about how to get political commitment from political leaders on malaria?
Let me start with what it means at a national level. I think demanding for attention on priority agendas by power blocks, by citizens, by civil society itself is a key motivator for political leaders to respond, to allocate resources, and to be visible. Sometimes that comes from beneath, meaning from the national spaces, and sometimes global actors can also press, and we see that, where the agendas that sometimes political leaders pursue are driven by a large part of supranational influences that leans on them to allocate resources. So changing that requires domestic constituency. We saw that with HIV, and I think we're seeing that with other diseases, and malaria will lead to really, given the burden that exists in terms of mobility and mortality, denormalizing it will require women, children, parents really speak about it, but also demand for action from their political leaders to allocate the resources. And I think that's an important element to generate that political commitment, but also to reward it when it happens or to punish it when it doesn't. How many political leaders will lose an election because malaria is getting out of hand, whether local politicians or national level politicians?
Good, thank you. Now, I'm curious, Mohammed, did you talk about malaria at the World Bank?
Yes, we did. We did in the context of our health portfolio. Of course, COVID-19 came, but the focus of our investments, $18 billion which the World Bank put out, was to strengthen primary health care as the basis. We, in a way, went in the direction of integration, seeing that picking diseases one at a time and getting them disconnected with the felt needs of communities isn't the best way to go, given what we've learned over the last 20 years. So the focus of the bank and the item in our strategy is really to make primary healthcare systems as a foundation for high quality health systems on the path of countries to UHC. And a functional primary healthcare system is one that deals with malaria effectively and that is financed also by those countries.
Good, thank you very much. Uche, since you're sitting now at the state level in Nigeria, but below the national level, what are your perceptions about the challenges of generating political commitment at the state level? State legislators, state politicians, governors. How can we get them to be committed to malaria elimination?
Yeah, thank you very much. I'd like to make one suggestion that I think might be a game changer here. And that is whether at the state level or national level, once the World Bank takes on malaria as a key issue, as its own program, all the presidents in sub-Saharan Africa will key into it. All the governors will key into it. We saw that from the river blindness control program when President McNamara took it on as a World Bank control program, World Bank-led control program. So if the rethinking of malaria becomes the program for the World Bank, every other thing, all the presidents, whether they like it or not, will key into it. And I'm sure my brother, Dr. Pate will agree with me. So at the state, at the local government, my governor will key into it because the president keys into it. That is for sure. And that will be the game changer for rethinking malaria. Let the World Bank step in and then you will see what happens. Thank you very much.
Good. Well, unfortunately, Dr. Pate has moved on from the World Bank back to the academic arena. So he can't.
But Michael, let me just say that in the context of Nigeria, the impact program, which the bank approved in February 2020, put substantial resources in Nigeria for malaria, but in an integrated manner that builds a primary healthcare system, immunization, malaria as part of that. And that is $650 million. That's a catalyst. But importantly, I think in the spirit of decolonization, domestic resources, Nigeria itself needs to put up the resources. I shudder to think what will happen if the global flows of financing stops from sort of the north to our countries to malaria program. That is the imbalance that the colonization in a way causes. So those conversations ought to happen, and the domestication of how we raise the resources, how we set the agenda, and how we execute with is quite important.
Good. Well, perhaps we can count on you for helping to give higher visibility to malaria within the political leadership in Nigeria. Deb, I'd like to ask you on this question of political commitment, the idea that the people should demand action from their leaders, and the people should hold their leaders accountable and their political institutions accountable for progress on malaria. This really requires a kind of social, cultural, and perceptual change by the people themselves. And as someone who has studied culture and societies, can you give us some hints on what could catalyze this kind of mobilization by communities in the fight against malaria?
Yeah, thank you very much. I think that we need to begin to let our communities trust us. And I'm saying we, in respect of whether we are managers of health policy or we are researchers or whoever we are in decision making on health, because they see us come to the communities, we collect data, they see interventions, and they know sometimes the monies which are being invested in health programs. But on the ground and in their own realities, they don't see much happening. And so sometimes when they are not adhering to the changes and to the interventions that we propose to them in the communities, it may be because they are protesting, and saying that you are doing all of these without us and we cannot conform or we will not conform. Is a kind of rebellion. And so we need to let our communities trust us that when we want to make interventions, when we go to collect data, it will bring real changes in the lives of the community people. And when money is voted into interventions, they would see the interventions being really implemented. And I believe that that is when we can all work together as community members and also as managers of health systems and health provision to achieve the kind of results we are looking for. I would also say that nations have to invest, and I agree very much with Professor Pate that nations have to be committed. We cannot continue to look up to the West. Some of us, we know what happened when structural adjustments, occurred, and when the Bretton Woods institutions made certain proposals that cut expenditure on health services, cut expenditure on education, cut expenditure on sanitation. And then we saw, sanitation go down, and then health indicators in certain areas became worsened. And so we have to take ownership for our own health provision. In Ghana now, we have COVID tax, and that is really interesting. While some people complain, the nation, the state is mobilizing some money for COVID intervention. And we've had malaria all these decades. How much are we mobilizing internally to execute our program? So that's a question. And I believe that when we do internal local mobilization and initiatives, community members also would feel like they have to hold us accountable because they are contributing to the resources which are being mobilized. And then they would request and make demands and ask, what are you doing? We want to see real results in our lives. And so all these things have to be put in place. And I believe some significant impact will be made. Thank you.
Thank you, Deb. If we think about data, as Professor Evelyn Ansa said, we've seen for COVID a really dramatic transformation in how public health data are communicated to political leaders and to the public. In many ways, the pandemic has been this global course on public health and epidemic control. And so, one of the questions that we've asked ourselves in Rethinking Malaria is, how can we do the same for malaria? So we see daily graphs of COVID cases, of transmission. We learn about asymptomatic transmission. How do we get the same level of data and data that serves to educate decision makers about malaria? Uche, do you have any thoughts on that?
My first reaction on this will be for us to try and partner with communities on data collection, but to make sure that as we partner with them, we also provide them a feedback on the data we collect at that level. And one of the speakers mentioned that in a very clear manner, not to collect data from communities and then abandon them, but to provide them with feedback. So in Rethinking Malaria, listening to the presentations, my takeaway here is that there is need in revising the direction of malaria elimination, for data collection and data upload and data management and use of data. There is need for an integrated approach, but malaria elimination program takes lead in that integrated approach. But at the community level, it will be very important to partner with the community, build the trust, and also allow them to realize that we trust in their ability to collect data once they are trained, in their ability to provide the data. And at the end of the day, we give them a feedback so that they are happy that they are not just there to be to collect data and we upload the data and we forget them. This will be my first thing. The lack of trust they have in us for the moment, at the moment, in many communities, is the challenge we will face in collecting data. The community leaders complained in many sites in the past couple of years that we collect the data from them, and then they no longer see us. After a couple of months or a year, another group comes back. So that feedback mechanism must be in place. But partnering with communities will help us, and then simplifying, as the presenter said, simplification of that data at the community level and building their capacity to collect the correct data is absolutely important. Thank you, Michael. Thank
you, that's very helpful. You know, I've felt for a long time that the role of trust and in public health has been underappreciated. If anything, the current pandemic has emphasized the importance of social trust, trust in institutions, trust in leaders, trust in data, trust in public health, trust even in simple things like masks has been illustrated. And I think the same applies in malaria. We need, as you said, Uche, mechanisms to rebuild trust in communities, in the methods for dealing with malaria. And that trust will happen when the actions actually produce tangible results for communities in preventing malaria deaths and malaria cases. Okay, we have 3 minutes left. Before we close the panel, I'd like to thank our distinguished panelists for their comments and thoughts. I'd like to give you each a 1-minute opportunity for suggestions of game changers. If you were to recommend one action to the Rethinking Malaria community to get us back on the path towards better governance and better delivery, what would it be? Deb?
Dismantle the disciplinary hierarchies in malaria research, adopt multidisciplinary approaches to gain better understanding, let communities own initiatives and programs on malaria. Thank you.
Good. You know, the disciplinary boundaries are actually constraining our ability to understand and act. Mohammed?
Taking off from the last discussion, massively expand testing all over and make it visible and connect it to the political leaders so that they can understand whether their health systems are doing what they're supposed to do or not doing so, and make it very visible.
Good. So make malaria visible and tangible, not just for the public, but for the political leaders. And I think that connects to your earlier point about generating demand and accountability for the political leaders on malaria. Uche?
Yeah, I would go for establishment or encouraging the schools of tropical medicine to hold a meeting and discuss the decolonization, perhaps encourage them to build research centers in endemic countries in sub-Saharan Africa, something like the Fakara. More of it is needed, and shifting the locus of power, including communities, investing in community participation, community engagement as an investment, that will yield value, not as an expense. So the investment and bringing community on board, for me, is absolutely crucial, and ensure, not only building trust, but allowing them to co-design the Rethinking Malaria program. For example, communities can co-design or design for us the indoor residual spraying and the larviciding. That they can do absolutely well, and we need them, and they can, and I'm sure we will benefit if we give them the opportunity to design what they think will be appropriate for those two activities. Thank you.
Thank you very much. So actually what you're saying is not just that the communities should trust the malaria community should trust the communities.
Absolutely, yes.
And that there should be a real transfer in the power to make decisions about programs. This is community-directed malaria elimination.
Yes.
Good. So I'd like to thank our three discussants for the conversation, for your thoughts, and for your contributions, and for your time. And this to conclude our first day of the webinar, we will turn to Diane Worth and Speciosa Wandera Kazibwe, and I'd like to thank everyone for their contributions today. Diane and Speciosa.
Great, thank you. Speciosa, over to you.
This has been very exciting. I tell you, I've been glued to my chair here in my study, and I can see through the closing panel all the points have been brought on board. Why should we entrench the colonization which Jesse talked about of extraction from global to national level, to district level, to community level? I think this is something which we have to look at and see how, Uche, we should really get our universities to talk about colonialism in the context of what's happening to our development. And in my country here, Uganda, we are talking about mindset change, but the mindset change has to be built on something which we know has gone to disenfranchise many of us and the way we think, because that's how we are trained. We are trained in those languages. We are everything. I've also been excited about Muhammad, when you said seed power to the communities, because Ni has been is in our team and is very, he's, if I may say, adamant, we must go to the communities. We must go to the communities. And then the issue of gender. Those of you who may know me in other colors, I'm a gender activist. And really the role of women has to come in very seriously and link it to our culture. The women were the doctors in their societies, the primary providers of care. So it is in their interest to own these community programs and also participate in ensuring that they come on board. I would like all the issues have been well articulated and summarized, but I want to talk to the issue of the role of universities, even before we talk about them, with respect to data, because I do have a personal experience in this. I did mobilize my community. My community trusts me because I live with them. I'm with them in everything, even during this COVID exercise. We plan with them, my parish. We plan and direct the technical people to actually vaccinate where we want them to vaccinate. And we did call the National Bureau of Statistics to help us generate statistics and make sure we work with the whole framework of delivery of services at the lowest government level, which is a sub-county. They were excited. We asked, how do you generate the district statistics? And they said, you know, through community participation now, we are going to be sure of the statistics. So I really want to thank you all for your participation, because governance at every level is key in making things happen. And to the malaria community and all the professional colleagues, if something works, why change it? Why change it? The fact is, it worked up to a particular extent. Now, the change has plateaued with respect to the indicators we are using. So we are entitled to change it, and change it in ways that will make us create impact. In other words, eliminate malaria in the areas where they are. So thank you very much, and over to you, Diane.
Great. Thank you, Speciosa, for those comments. And thanks to all of the speakers and panelists for what I think was really a robust discussion and some tough questions. So it's up to me to thank all of our sponsors and partnering institutions. We've reached reached out to a large number of people during this process, and this will continue tomorrow. So I invite all of you to return for the second day of this webinar, same time, same place tomorrow to continue our discussions. And with that, I wish you good evening, good afternoon, and good late morning. Thanks to everyone.